This webinar is brought to you in partnership by the Association on Aging in New York, the New York State Coalition on Aging, Council of Senior Centers and Services of New York City, and the New York State Office for the Aging. We're really very happy to have you all here today. I think it's going to be a great session. I know I'm really excited. Please pardon, I'm just getting over a cold, so I sound a little funky. I apologize. I want to go over a few logistical things before I hand off to our fine presenter today. We're expecting close to 200 folks on the webinar, so everyone will be muted throughout the session. There is an area on the webinar panel that says questions. I really encourage you to use that throughout the session to share your questions, and we're going to address them throughout. We're going to pause for questions at several points throughout the presentation. So please use that questions panel liberally. We'll do our best to get to as many of them as possible. This webinar is being recorded, and the session, along with the PowerPoint, will be uploaded to the association website after our webinar conference today. Probably be up by tomorrow or so. Give us a few moments to get it ready, and we'll get it up there. The website is www.agingny.org. Let me repeat that, www.agingny.org. It's going to be under the Education and Events/Webinars section. I will share that link throughout the presentation. All right, so I think we've got over all of those logistical things, so I'd like to introduce our presenter. We are pleased to have Dr. Marie Ampere presenting with us today. She is a clinical social worker at the Mount Sinai Hospital, the co-director of the ADAC, and has extensive experience in the area of aging and mental health, delivering psychosocial care to elderly patients and their families. Mari also develops and implements health education programs for older people, their families, and their caregivers. So without further ado, I'm going to switch over to you and get us started. So welcome.
Hello.
Welcome. You are on the air and live.
Great. So thank you very much for the opportunity to speak with all of you today. We are going to be talking about geriatric mental health. We're going to focus on 3 specific areas of mental health. We're going to talk about anxiety, we're going to talk about depression, we're going to talk about memory loss. As you probably all know, about 10,000 baby boomers in the United States turn 65 every day. So that means a number of people are getting older. Some of us have talked about these phenomena as the gray tsunami, baby boomers getting older. However, we know that as we live longer, we encounter some health problems. However, sometimes we don't pay enough attention to the issue of mental health. So today we're going to stress the importance of a healthier life that includes paying attention to mental health. So today we're going to provide an overview of mental health in older adults. We'll discuss how mental health and physical health impact well-being. We will provide you with tools to begin to recognize how important mental health issues are in older adults. And as I said, we'll talk a little bit about depression, anxiety, and memory loss. And through the chat, I would like to hear from you and your specific concerns around these topics. So we will have some time to stop and have some questions. So overall, I hope that today you increase your level of comfort engaging older adults in conversations about their general health, and that these conversations include their mental health. And also we will hope to help you to become familiar with resources available to you so that you can serve your older clients at risk for depression, anxiety, or memory loss effectively. So what challenges come to mind regarding your clients and their mental health needs? Does anyone have experience working in mental health settings out there with older adults? Any Any thoughts about these? Alisa, Carol, any thoughts about these from the audience?
So I'm waiting for folks to pipe in on that. Please feel free to share about that. But I know a lot of folks are dealing with many different situations, many clients who may have mental health issues, and some of them may not be aware of it, or may have know their specific diagnoses. What are some of the common challenges? One person just shared that sometimes the clients don't realize that they have a challenge.
Precisely. So that makes it really difficult for folks to put their thoughts and feelings into words in a nice package, letting us know specifically that they're having concern about their emotional health.
Mm-hmm.
So
we also have
so
a couple
many
of
barriers to mental health. Sorry.
They're just coming in right now, so let me share some of these thoughts that folks are sharing with us. In addition to clients not realizing they have a problem, some folks have experience working with folks with anxiety, which I know you're going to talk about, refusal to use services, or people who are resistant to treatment. And, of course, not enough mental health services available in the community. Those are some of the big challenges people are piping in with.
Well, myth and misinformation is a big barrier to mental health care. There's, as you probably all know, an enormous stigma associated to mental health services delivery, help seeking. There is a serious misunderstanding among older adults about what constitutes the normal aging process, what is a disease, specifically around mental health, for example. Some people may refuse services because they are not aware of what psychological services may entail. For example, those people that have been born before 1946 tend to have had less access to education, are less psychologically minded than, let's say, younger generations. In terms of like accessing care, of course, the services are fragmented. And that makes it even harder because sometimes even in healthcare situations, like for example, if you walk into the different doors through that you can enter the hospital or the healthcare system. Even within the healthcare system, there is some stigma attached to mental health use. So it may be possible that the same providers that are providing healthcare to your clients may not be aware of your client's particular mental health services needs, and they may not know how to engage them in a conversation about that. And there are some unrealistic beliefs and expectations regarding the use of services, and there is an association, interestingly enough, to the type of care that was available to patients with psychiatric care as these elderly people were growing up. And there's a real association among the public between what psychological care is for someone that is in the severe mentally ill category and, you know, the person who may be having a grief reaction, sadness, depression, anxiety, or more like garden variety of mental health problems. So that is a misconception and a myth and a barrier to care that hopefully today we'll be able to demystify a little bit. So, speaking about knowledge, beliefs, and attitudes, what you see on the screen right now, I hope, is a helmet with wires. And the reason we came up with this helmet with wires is that after conducting a series of focus groups in the community over the summer, we learned that our key finding throughout these 7 focus groups, which were all about mental health services and the aging population, and we conducted the surveys with actual seniors at senior centers. So the general knowledge was that when you seek care or information or diagnosis for memory loss or any problems that have to do with your mental health, you end up with wires in your head. So we wanted to demystify this, and we've created a video and used this specific visual image to sort of like cross this out and clarify that wires in the head are not a requirement for a mental health services evaluation or to better understand how your memory is functioning, whether you're depressed or whether you're anxious. Later on, I will discuss in a little bit more detail what types of tools we may have available to evaluate older adults' mental health problems and identify them and diagnose them. So any other question that we should address right now? Refusing services, we talked about resistance to care. Well, actually, if you think of care involving something that looks like this, it's conceivable that you're not going to want to go see anybody who will give you cables in your head. So that could be clarified and better understood through a sort of like focused conversation with your service receiver, with some exploration in a gentle and kind, supportive way. So we're moving on to talking about depression, anxiety, and then memory loss. A lot of the senior center participants I encounter in my day-to-day work are very concerned about their memory, and many are convinced that memory disorders are just part of aging and that inevitably one day they'll just lose their mind completely and they will not remember anything, and they live in fear of when that day will come. So we do know that as we get older, this is not a myth, this is a reality. We are going to just lose a little bit of our mental abilities, only because as we get older, things slow down, and that includes our memory. Depression also interferes with memory functioning and cognition. So when an elderly person is depressed, one of the key signs is that they seem or appear to be having more memory and concentration problems. And depression overall is not just feeling blue or feeling sad. Depression is a feeling of sadness that lasts for a significant amount of time, and it doesn't go away. It interferes with activities of daily living, it interferes with sleep, appetite, and it also impacts energy level. And like I said, with older adults, it definitely interferes or impacts their memory and cognition. So depressive disorders are under-recognized, they're under-treated, and at times they're not even treated among older adults. And they definitely lead to impairments in physical, mental, and even interpersonal functioning. These disorders often come together with other chronic diseases because, as you probably all know, as you get older, there are some medical conditions that are going to come up. Everything slows down, the body deteriorates, and the interaction of the mind and the body may create more problems. But that interaction can also be very useful in the healing process. So with older adults who suffer from depression and are not identified, they tend to visit the emergency room very frequently, or at least more frequently than regular folks. They use more medication, and they incur in more expenses through their health care. And because they're seeking care through the wrong door, like I said. Earlier in my career, I worked in an internal medicine clinic where we saw a fair amount of patients that were approaching 65 or older. And some of these patients were, we called them at the time, I don't remember the term we used, but it was something like frequent flyers, because they came to the emergency room very, very frequently. And this is where the interaction of psychosocial stress, anxiety, depression, and fear of a medical condition got together. So we have these very, very anxious people coming into the emergency room, getting a $1 million workup for a zero diagnosis. There was like nothing wrong, although the persons who were experiencing the discomfort were feeling disappointed, they were feeling mistrusting, and they were feeling like they were not getting care. So we started a project to engage those frequent emergency room users in a group program to identify and begin to get to know them, to see what was going on in their emotional world that could be exacerbating whatever experience they were having. And we found out an amount of information that was very useful in creating adequate services for them. Some were grandparent caregivers of very young children who were at the time sort of like part of that generation of kids that were born when parents were HIV infected, were IV drug users, were incarcerated, and the grandparents became the National Guard for the family. However, they didn't have enough support or enough paperwork. They were not even officially the parenting person responsible for their kids. So we started untangling a big web. And this is one of the things that is important, that older adults at times will seek services for their physical conditions. However, they may not be able to clearly present what's going on at home or in their emotional world to their providers. And as we connect with seniors more regularly than even their healthcare providers, we can have a key role in helping them to find the appropriate care. So as I tried to explain earlier, depression and anxiety sometimes present together in the older adult population. They're debilitating and they reduce overall health and, very important, their quality of life. So one of the things that I should mention is that these seniors that I encountered with frequent users of the emergency room were extremely worried and apprehensive of their medical conditions. They experienced chest pains, they experienced severe shortness of breath. They experienced a disproportional alarm to their bodily symptoms, and they were so worried and, just so concerned that they could not sit at home because they felt they needed immediate attention. So a lot of them had difficulties relaxing, sleeping, and concentrating. Many of them, interestingly enough, had seen a healthcare provider who had the vision of prescribing a medicine to help with their anxiety. However, they were not necessarily engaged in some ongoing psychosocial exploration of what was causing the anxiety. So at times in those days, that was about 20 years ago, people would end up getting benzodiazepines, which are anti-anxiety medications that are meant to be used short-term. In the elderly, these medications can cause severe sedation, and they can also present, when a person is severely sedated, that person can present with some type of memory problem that then gets perceived by all of us as like, okay, this is potentially Alzheimer's disease emerging. So all of these things get very complicated, and when we try to fix one thing, we may end up like ruining another. So this is why working with the elderly is a little bit like being a private investigator, and you have to like always be very curious and very alert to multiple medical conditions and multiple medical providers treating the person who may not necessarily be connecting the dots. So the pharmacist becomes an important part of this equation when the seniors go, at least if they go to the same pharmacy, somebody can be keeping track of the what we call polypharmacy. So how do we know that somebody is suffering from depression? We have several tools, and this is a very simple one, that at least these questions, I'm not expecting you to actually conduct an interview with each one of your care receivers. However, if you're if you're familiar with these types of questions, you will be able to sort of like look for these things. For example, if you see somebody who appears to be basically satisfied with his or her life, but you notice that they've dropped many of their activities and interests, if they complain of being bored, if they feel and look like they're in good spirits most of the time, do you think they're overly worried? Do they feel happy or they appear happy? So these are the types of questions that we ask our patients when they come into the office and we are wearing the clinician's hat. So a score of 5 or more points indicates that a healthcare provider should be contacted for further evaluation. And so these could be one specific way, a quantitative way to help your seniors seek care. If you're able to engage them in having a conversation and then you say, you know what, why don't we just go through these little questions and see what your score is, and we can see what is your number. And with this number, you can have like externalize the problem. You can call it, you know what, you have a low number in your quality of life, or you can call it whatever you think is best. I am in favor of like using a language that patients are going to be receptive to. And it takes time to get to know what people, what resonates with people. So maybe depression is a good word to use. So today, for example, I did a memory and aging workshop in the community. And what I asked our participants today is like, do you know your memory number? And everybody was like, what's that? So basically, we'll talk later about the memory number, but I'm trying to think of how we have helped people take care and be more empowered in terms of their own health, and we've taught them to know their blood pressure number, their cholesterol number, their blood sugar. So I'm trying to help patients out there in the community or just seniors in general to get curious about their numbers that have to do with their emotional life. So one of the numbers that we talk about is the memory number. That seems to be important. So this is another way to engage in a conversation, just thinking about numbers, and people seem to connect with that. So this brings us to memory loss. So today I talked to this group of seniors at Gaylord White, right around the corner from where I am right now. And we talked about how memory loss is a normal part of aging. We talked about the fact that memory disorders are pathological. And like I said to them, we have good news and we have bad news. The good news is that memory loss is a normal part of aging. The bad news is that there are some memory problems that are complicated and that are more prevalent in older people, and we still have to be on the alert to see whether these things are emerging. And then the conversation goes into, well, why would I want to know if there's nothing that we can do about it? Well, although we cannot cure these problems or disorders, we can certainly treat them, we can identify them, and we can help people stay healthier longer and keep their memory as healthy as possible for a longer period of time with adequate care and services. So what are the most common memory disorders? Alzheimer's disease, vascular dementia, Parkinson's disease. Any of you out there have experience working with patients or seniors that present with memory issues?
Yeah, there's definitely some
Alzheimer's
people
disease, for example, is
there's definitely some folks who'll have experiences with that. I'm waiting for folks to share their stories, but absolutely, they'll see that in many different ways.
and that seems to be the number one factor that worries older adults. I think there was an article several years ago on the New York Times, even on the cover, it said that fear of Alzheimer's disease or any other dementia was even higher than fear of death among the elderly. And I have seen that in my own experience working in the community. So one of the things that I think is very important is to be reassuring and to help seniors understand that memory disorders are not a normal part of aging, and that although there is no cure, there is certainly help out there, and that may be one way of decreasing anxiety, because when people feel anxious, they also have problems concentrating. Their quality of life decreases as they are not able to perform at their optimal level, even though they are not as their memory is not as deteriorated as it appears to be, only because of the anxiety and the depression that are covering up what might be going on there in terms of the memory issues. So it's very hard to evaluate a memory disorder when we see a patient the first time and that patient looks depressed or overly anxious. So we start by treating these conditions, by helping patients through evaluations. And also, one of the things that's really important to take home, an important message to take home, is that there is treatment for depression. And 80% of those who are treated for depression improve and recover their memory issues, because when we see them, their memory issues are really related to depression rather than to a memory disorder itself. Any questions coming up, Carol?
Yes, I actually got a really great question. It's not quite related to exactly what you're speaking, but I thought it was a wonderful question for us just to discuss for a second. So aside from connecting a participant in a senior center with mental health care or an in-house social worker, if there is one present, what are some specific methods for non-social workers to navigate disruptive and antagonistic behavior displayed at senior programs? Any thoughts on that?
That is an excellent question. I can tell you it's excellent. You know, you think when you find people with disruptive behaviors, there's a variety of levels of the disruption. And I believe the first and most important thing is to assess whether you or the rest of the clients are at risk. And once you've made that assessment and there is no imminent risk, there is a person that is really in distress, you want to distract the person, first and foremost, from the distressful situation. You want to get that person to sort of like separate from the rest of the group if it's in a group situation. And you want to gently and kindly modulate your voice so that you can help that person calm down. And it's not foolproof. It's not a foolproof method. This is not something that is easy to accomplish. However, if you think of like older adults, they're sort of in a process of retrogression rather than progression. So their bodies and minds are sort of going in the opposite direction of children. When we're raising kids, we want them to become independent, and we want them to try new things, and we want them to slowly sort of like get more mature. with older adults, their ability for self-control, instead of improving, is decreasing. They get short-tempered, they have less tolerance for discomfort and pain. Mm-hmm. And one of the causes of disruptive behavior and agitation could be related to an underlying medical condition. For example, one of the things that is important that I didn't even know before I started working in the aging field is that urinary tract infections present in ways that are almost imperceivable to the rest of us. Yes. And so a person with a urinary tract infection may appear belligerent, may appear disruptive, may appear agitated, aggressive, personality changes, memory loss, up to the point of delirium. And there's that medical condition going on underneath. So in general, to summarize, in terms of like dealing with disruptive behaviors, first and foremost, be careful and be self-protective and protect the rest of the seniors and staff. If you're going to meet with a person that is, that you're concerned about, sit close to the door. Do not turn your back. Maintain some contact to make sure that, visually you know where that person is going, and maintain a safe distance from that person, and at the same time lower your voice and speak in a gentle but firm manner, and evaluate whether there's the need to call the doctor, or sometimes there's even the need to call 911. We've certainly had those situations in our clinic when patients come in and they just have a reaction to the questions we are addressing because they trigger something. And we've had to call, we have a system in the hospital where we call security, and security helps us to escort the patient to the emergency room. And so safety is really the #1 issue. I hope I have addressed this question. Any other thoughts or concerns around these type of situations in the field?
That was great. Thank you so much for addressing that. I think that did a little bit. If folks have a follow-up question to that, please feel free to pipe in and let us know. But otherwise, thank you so much. Let's continue.
So what you see on the screen right now, which is probably a little bit hard to read, is a mini mental state exam. And this is what we use as the very rough first screening when we see seniors in the hospital to evaluate them for memory issues. So we have a full dementia workup that includes multiple psychological tests, but this is the first one we do. And in the last few years, I've taken this out to the community, and this is the test that the 100% score is number 30. We get concerned in this specific area, and I will see if I can point it out here. This part that says immediate recall, we ask the patients to listen to 3 words, repeat them and memorize them so that we can then ask them what they are. If a person misses one or more of these 3 words, we want to check that, and we want to make sure that there's nothing else going on. So we also ask them like some things that on a day-to-day social conversation you don't ask. For example, can you spell the word world backwards? We don't have sometimes great responses to these, because when people are feeling that this is going to uncover a problem, they get resistant. And as somebody mentioned before, some of them just right out refuse because they don't want to know. And so what we tend to do is we tell them that we're going to sit with them for a little while to just tell them about it, so that maybe they can bring this up to their doctors. Because sometimes in general medical practices, memory, for example, not every doctor uses a mini mental to evaluate their just general medical visits. So these are two tools that we use, the Geriatric Depression Scale and the Mini Mental State Exam. They're sort of like part of the bread and butter of geriatric mental health. So I wonder if by now you're thinking, okay, so how do I figure it out? I'm not a social worker, I'm not a psychiatrist, I'm not a mental health provider. There's not even one in sight, there might not even be one in my community. What do I do? So between Stephanie Kearns, my intern, and we came up with some step-by-step ways of spotting depression. So we hope that this is useful for you. So here we go. Be aware of contradictions. Any thoughts about contradictions in working with the elderly? Anybody has experienced these contradictions in their interpersonal style out there? So older individuals sometimes appear depressed, but like you said, they don't acknowledge it. So we need to be mindful of that and try to figure out ways to enter into their field of, I guess, into their inner circle. And through my focus groups over the summer, we asked the seniors this question: who is your trusted advisor? And to my surprise, one of the most frequent trusted advisors was the director of the senior center. And that was very surprising because we were anticipating that seniors would be more trusting in terms of their health care of their medical doctors. And it was not like that in this specific community. So entering their inner circle and acknowledging the fact that even if you don't know it, you are already a trusted advisor is of help in, this step-by-step approach. So look for persistent and vague complaints, slow-moving, behavior and attitudes that seem to be changing. Sometimes seniors, when they're feeling vulnerable, they become more demanding and they appear to be rude, which in fact they are really under severe stress. Physical conditions. Pain comes sometimes in combination. Emotional pain gets reinforced often by physical pain. Any questions, comments, thoughts, ideas? Carol?
This is great. I'm thinking how common it is, especially amongst older adults, to not acknowledge those feelings of sadness and depression out of fear, but rather, like you're saying, expressing it in the physical pain. I think that's so important to reinforce that. That's great.
So it's also important that sometimes when we see a person that has multiple somatic complaints or that's always sick, always has something, you want to say, okay, this is a red flag. Let's observe. So somebody may have had a stroke, a heart attack. Somebody may be struggling with a hip fracture and not even know it. Somebody may be dealing with macular degeneration, which is a very common and pervasive disease that really robs seniors from their vision. And that is really sad because it really changes one's life. Like they do not have the ability to see in focus. So they have better peripheral than central vision. So they see the world in a very distorted way. Reading becomes a problem for those who are good readers. So it becomes a little, it increases feelings of loneliness and isolation. So depression and anxiety can complicate recovery from all of these and can also hide all of these together. If a person is depressed, she may not really report. They can either be over-reporters or under-reporters of their medical conditions. And then the recovery becomes slower. So recovery from surgery can be compromised by depression because it is believed that depression really impacts the immune system. So problems are encountered with discharging people from the hospital sometimes when there's depression. So as I mentioned earlier, a key misperception is that depression is part of growing older. It's really not. But we do know that depression symptoms may increase with age because of the comorbidities between medical and physical problems and how these may impact quality of life, which then impacts mental health and emotional well-being and ends up in being a full-blown depression. But as I said earlier, 80% of depression is treatable and responds to treatment. However, I know that many seniors are not receptive to taking medications, and many will not be receptive to seeking or accepting care. So it is a very challenging combination. So what challenges come to mind regarding the process of identifying depression, anxiety, and memory loss in older clients? Any thoughts, Carol?
So while we're waiting for some folks to send in their questions, excuse me, I'm wondering if you could share with our attendees some techniques for bringing these challenges up. We've had a couple of comments and questions about, how do I really approach this with seniors? Do you have any best practices that you'd like to share while we're waiting for some additional questions to come in?
Well, one of the things that has helped me in working with older adults is not necessarily to talk about situations or worries or concerns directly, but indirectly. I tend to ask open-ended questions and engage seniors in telling me their life stories, and most of the time that has worked. Other things that I have found useful in the work that I've done in the community is to engage seniors in some kind of activity. And through this indirect method, for example, doing collages or doing some art projects, they may seem a little resistant at the beginning, but then they get into it. And then when you start asking them questions about their art project, then emotional concerns come up. And that has been one bridge to connecting with seniors that are less receptive to talking. In a one-to-one situation, when things are like hectic and there's no time for activities and there's no time for group, definitely just being respectful and gentle, inquisitive in a very respectful but curious way may yield some positive results. And try again. Don't give up. It is not a straight path. It takes several tries, but keep engaging them so that they know you're there and they know that they can trust you, because that's the part that we sometimes don't even realize, how much they trust us even though they don't seem to show that we are part of their inner circle.
That's great. Those are some great tips. You know what folks are bringing up in the chat is the relationship between the senior and their primary care physician, and how there's a very strong trust factor there, that they're apt to talk to their primary care physician about some of these issues as well, and sometimes the primary care physician will prescribe medication for mental health challenges or diagnose there. Can you talk a little bit about the the pluses and the minuses of that?
I think that's an excellent question, and I think it is fantastic when seniors can trust their primary care providers and when they feel they have enough time to engage in conversations that are meaningful and important. In my neighborhood over here in East Harlem, the seniors were not feeling as stressful and as welcomed, because they feel doctors are very quick and they don't have enough time to listen to them. So it's great to hear that out there are some doctors that have time. And those doctors are probably in a very good place to identify these conditions in the elderly and to make appropriate pharmacologic recommendations and start seniors in good medications. However, I think that there's always room for psychosocial interventions, and it is probably tricky when a person with depression has other chronic medical conditions that require medication. So it is a tricky place, and I do respect the work of primary care providers in the community when they have the time to make good and careful assessments. And in working with seniors, it's almost like working with families and with younger children. You want to set up a team approach. So when I worked with kids, I used to engage the teachers, the parents, and the mental health providers in teamwork. With seniors, I think this is key. A lot of seniors have paid caregivers, at least in this community, and the paid caregivers are key informants in our meetings with the geriatric psychiatrist and the patient, because these caregivers are part of the family. They observe the seniors, although they can't tell the seniors what to do. They can encourage them and they can provide support. So those are good informants. So establishing a team approach is very useful. And maybe family members could be engaged in the interaction when there are concerns, because sometimes seniors themselves subjectively, they don't see what's going on. They just don't have that ability to self-observe. And it also depends on the person. Some people throughout their life cycle have no ability for self-observation, and others are very attuned to themselves and their bodies. So I am in favor, to summarize, of primary care providers in the community providing quality care. However, there is also the flip side of the coin. Not everybody is a geriatric psychiatry expert. And as I said, medications tend to be more, let's put it this way. Seniors may be more sensitive to medications because of the changes in metabolism that go on as one gets older. So the medical providers are hopefully aware of the need to be mindful of these metabolism changes as people get older, and better medicines to use with the elderly than with just the regular adults or even with kids.
Great, so excellent points.
Thank you.
Mm-hmm. Someone has brought up one of the biggest challenges that comes to mind for them in this process is distinguishing grief in the picture when an older adult experiences a loss of a partner or a loss of a family member, and also the loneliness when you have older adults who are not getting the family attention, perhaps we could call it. Family just isn't visiting as much, or maybe they've moved away. So that grief and that loneliness are some of the big challenges that come to mind.
So those are excellent questions. Specifically, as you bring the question, we have been talking about establishing I work in an enriched housing residence here in East Harlem that is associated to the Mount Sinai School of Medicine, and we visit the residents regularly. We host a women's memory enhancement group, and we have noticed that there is an undercurrent of grief and sadness and loss that has not necessarily been addressed. How do we address that? We have thought just like the last few days, that we should create a workshop to teach from a psychoeducation perspective about normal grief associated to the loss of a loved one. sometimes in our society we don't give ourselves permission to be sad. There's so much emphasis on sort of like youthful attitudes and happiness and just like grin and bear it and you have to move on, that we don't really give ourselves the opportunity to really grieve. And that's a natural part of, you know, death is a natural part of life. We're not necessarily well equipped to deal with it across our life cycle. Hardly anybody talks about death and dying. So when we suffer a loss, it almost becomes like a shock. And then we're in the middle of it and we have multiple feelings: shame, doubt, fear, sadness. We regress and we, you know, kind of like the one present loss gets combined with all other losses from our past, and it becomes one big difficult thing to deal with. And then, to complicate matters even worse, sometimes we medicalize that and we call it depression. So there is somewhat of a rule of thumb, so to speak, that indicates that 1 year of mourning is a natural process, and it takes about 1 year to mourn the loss of a loved one. And you may wonder, well, why 1 year? Well, through the 1 year, we go through like all the holidays. We have the opportunity to accept that that person will not be there with us, as you know, things are different. And time provides the opportunity for self-healing in ways that are sometimes unconsciously, that are happening unconsciously and that are happening kind of like underneath the surface. However, when that grief turns into a clinical depression, we need to step in and help the person. So that's why we thought that an educational workshop for seniors would be useful, at least in this setting where there are a lot of seniors and there is a lot of loss, because that is one part of aging that is inevitable. We are going to, as we get older, we are going to lose more of our inner circle, our family members. And, you know, we hope that they are not time disordered losses, because it's really very hard for a senior to lose an adult child, to lose a grandchild or even a great-grandchild, and it happens. So those are outstanding situations that require some extra support. However, normalizing the sadness and the grief after someone close dies is really very important and doesn't happen enough.
That's great. Thank you.
So I wondered, does anyone have experience like trying to figure out this combination between depression, anxiety, normal memory decline, mild Alzheimer's disease? Has anybody thought about that out there?
So a couple of folks have commented, you know, that they're, excuse me, my voice is not functioning properly. I apologize. A couple of people have asked, you know, how do you help the spouse in the case of someone who's been diagnosed with Alzheimer's or any of these challenges? What about the other person?
Excellent question. I think that is so important, and it is one of the things that I also do in my day-to-day practice. We have had an ongoing support group for Alzheimer's disease spouses and family members that has been going uninterruptedly for about 10 years now. And that group is really the lifeline for its members. It is such a unique experience to lose someone very, very slowly. It's almost like a long goodbye. And we've had the opportunity of helping the caregivers turn the situation around, and it has given them, you know, different people react to different challenges in, you know, unique and different ways. So in this group, the group has come together, and these specific participants have turned this experience into a privilege. They feel very, very honored to have the opportunity of, you know, sort of like loaning their brain to their spouse. But they also know that it is important to begin to understand that these symptoms that they're observing, like for example, like behavioral disturbances, the challenges in terms of expression, the fact that they sometimes call their husband, they confuse the husband with the father, they're very shocking and they're very sad. But they can help the caregiver sort of like understand that it's a process of like detachment and disengagement, because the person is no longer that same person that they used to know. The person is sort of like in an ambiguous process where sometimes they are themselves and sometimes they're kind of like the embodiment of the disease. So that has been helpful to impart knowledge and help the caregiver become as familiar as possible with the condition and with what to expect. And definitely support validation of their experiences, and opportunities for recreation and respite are also key factors in the successful of keeping somebody at home successfully with these conditions. However, when it's mild Alzheimer's disease, it's even trickier, because you don't want to medicalize and make the person more dependent than they already are. And that's another tricky part. Like, how do you protect the patient, keep the caregiver free from anxiety, but maintain the patient at a, optimal level of functioning? Not an easy recipe, but always important to maintain communication.
Great. Thank you so
Any other
much.
questions or thoughts?
No, I think we've got mostly everything taken care of.
Yeah, go ahead. Carol?
Yep, I think we hit all the big questions. Thanks.
Okay, so how much more time do we have?
We have just about 15 minutes.
Okay, so I have prepared some slides to address the topic of communication, because as you have seen, we've been talking about challenges in engaging, the importance of providing support, the importance of validation, the importance of recognizing what's going on. So really the most important tool we have when dealing with mental health issues are our words. So we want to make sure that we communicate, and we tend to communicate through conversations and words, even though, of course, gestures and postures are very important. Activities are also ways of connecting. Ultimately, we want our seniors and ourselves to be better able to put our thoughts and our feelings into words. And communication is impacted not only by, well, our language, but it's also impacted by our culture. So important thing to have in mind is cultural sensitivity and awareness, and also the fact that we are going to experience some communication challenges with older people because of the of the natural process of aging, memory loss, hearing loss, vision loss. So we can run quickly through these cultural sensitivity things. So what's the identified, we need to identify what are the ideal language for the senior to speak if we have the opportunity to speak their native language. Some of us work in neighborhoods where the majority of seniors are foreign born, especially here in East Harlem. I work with a Latino population, foreign born, but who grew up right here in the neighborhood, and they speak in a different kind of language. Let's say it's a code switch. They speak some words in English, some words in Spanish, and we like go back and forth very naturally. Some of these will create language barriers, because if you're not really from East Harlem and you come in and you hear people speaking half English, half Spanish, you're like wondering what's going on. So we need to understand the cultural context of the seniors we are working with, and we want to be respectful, but also respectfully curious, so we actually get to know them better. Their personal style, their preferences, and also one of the things that I've also learned that's very important is the formality or informality that they prefer to use in their interactions. Some seniors come from a time and a place where formality was highly valued. And as time goes by, I think we have become a much more informal culture and society. So we need to be respectfully curious about that. What is their cultural identification? Do they understand? Double check. Do not make assumptions, but be curious about their beliefs. Religious beliefs and religious practices and spiritual beliefs tend to be important in working with seniors. However, we don't want to make assumptions, so we want to be respectful. Again, in a curious way. How do we establish trust? How do we help them recover from trust? From mistrust. Let's say we make a mistake, and we all make blunders occasionally. So how do we help recover from that? How do we help them recover from their own blunders that are going to happen? And sometimes seniors are very, very hard on themselves. So being aware of that is important. Diet. How important is diet to mental health? Well, I think we all know, or at least some of us know, that chocolate really makes a big difference. If we can no longer have the things we like, we're going to suffer, and it's going to be experienced as a loss. Do we help seniors sort of figure out how to modify their day-to-day diet so that they can have some sense of satisfaction and they don't feel like they've been punished? Because sometimes these dietary requirements are so strict that people feel like, what's it? Either they totally give up or they become overly vigilant. So when you are trying to figure out how to enter their world, think of this as a cultural assessment, and also think about maybe your own provider bias. That's how we talk to the medical students here in the clinic and in the medical school. We just want to make sure that we are somewhat self-aware of our own expectations and beliefs about what it means to be old, what people are supposed to be like when they're old. What do we think about that? And whether how we think about it is influenced by the place we come from. So what are some communication challenges with seniors? So all that I mentioned earlier, these cultural aspects of communication are going to get even more complicated when we think about the fact that there's going to be hearing loss, vision loss, memory loss, and that seniors are not going to be retaining information as efficiently as they did earlier in their lives. They're going to process things slower, and they're going to maybe, one of the things that I tell my seniors when I go to the senior center is sometimes things come in one ear and out the other. And what does that do to the person that, to you when you're trying to communicate something to someone who's not really kind of paying attention? So it's going to get you frustrated. So you need to know that you're sometimes going to get frustrated, and sometimes you're going to think that if a person has difficulties with hearing and they speak another language and you speak louder to them, they're gonna understand you better. It doesn't always work that way. So it's important to take a step back, take a deep breath, and make an assessment of how to best connect with that person, keeping in mind these details. And speaking about attention, you really want to make sure you have their attention, because as I said, focusing may take a little bit of time. Facing the person when you speak will allow that person to read your lips. Maintaining eye contact will help that person know that you're interested. Speaking slowly and clearly is also very important. For me, I have a high-pitched voice, as you probably can hear, and that sometimes is very hard for seniors to hear. So I have to be very mindful of my breathing. I have to take a step back and sometimes repeat what I want to say in a clear and slow way so that they can connect. I try to keep my mouth visible. I definitely avoid shouting. Using simple words and sentences is important. Sometimes it's not so easy because we're so used to like working in a medical environment where we talk this language that is probably not necessarily the language of every day. So I am prepared to repeat, revise what I have said several times. And very important is to stick to one topic at a time. So when we do the workshops in the community, we have become very, very mindful of literacy issues and how important it is to remember that some of the seniors didn't actually go to higher levels of education. And even though they appear to be functioning perfectly in the world, some of them are actually illiterate. And that changes the way in which you take information in. So information overload is a big problem in our society. Sometimes people are just given too much information, and that's one of the things that the seniors in the focus groups requested. Can you please give us information in a simple way? We don't understand long medical terms. So we created some health education materials that take all of this into consideration. And so we give the patient enough time to answer their questions and to express their ideas in a conversation. We also summarize for them. And I repeat what they've said to make sure that I've understood it correctly. And I seek clarification from them as well in a conversation. Like I said, sometimes it's just the days goes by really fast and you have many things to do and you have many people waiting and there's many people demanding your attention. So we tend to finish their sentences. We tell them to like either move or, you know, sort of like whatever. So an enormous amount of patience is required in these settings with seniors, and maintaining our composure is really important, but we can't expect that from them. We need to expect inconsistencies, errors, emotional outbursts, and communication breakdowns. So good communication often depends on good listening from both parts, but we can't expect seniors to have excellent listening skills because they are having difficulties with hearing loss. That is the first thing that goes as we get older. So when hearing loss is an issue, it should be addressed, and it's not cheap. I mean, getting hearing aids is very expensive, and it's also a real injury to one's self-esteem and self-perception. It has meaning for people, and we need to engage in conversations to try to understand what it means to them so we can provide support, clarification, and validation of those feelings. So to summarize, what are the key points to keep in mind? Some deficits in memory, hearing, and or vision are part of normal aging. General health and well-being includes mental health. Engaging our clients in conversations about mental health is challenging, but I urge you not to give up and to give us a call. Maybe we can help you. So thank you so much. Any thoughts, questions?
Thank you so much. That was great. I have a couple of additional questions that we can try to hit in the last few minutes, but I did just want to let folks know that as you're logging off in 5 minutes, hope you don't leave us early, but if you have to go, we understand. There will be a quick survey. If you guys could just fill that out, we really appreciate any feedback that you have. And thank you so much. This was just very informative. one of the interesting questions that came up about the communications is, someone is finding it difficult to speak with a loud voice because they fear that it appears that they're screaming at the person, and that when they speak louder, their facial expression actually changes. And of course, it's quite difficult to do any of this stuff over the phone. Do you have any recommendations in those instances?
Well, I definitely do not encourage speaking loud. I think it's very important to speak clearly and to also be mindful that you may need to raise your voice and be mindful of the tone. So it's not screaming, but it's really articulating more clearly. And definitely on the phone, it is very difficult. And there are some I think there are some specific devices that can be used by seniors in their homes along with their telephones. I mean, there are so many varieties of telephones these days that I'm not exactly sure whether, you know, you need a specific type of phone, but there are amplifiers that the seniors can obtain, and I believe at times these devices are covered by insurance, but I cannot tell you 100%. But I can certainly find out if people need this specific information. I can try to do some research and see if I can send you some resources.
That's great. Thank you. I know someone just chatted in that CapTel is a program that shows words when a person can't hear. We'll do our best to throw some of these other resources on the website once we're posting the recording of the webinar in the notes, and we'll post this website that was just shared with that. We have literally 2 minutes left, so I just want to thank you so much. I thought this was a really great presentation. I hope everyone enjoyed it and learned something. There's a couple of additional questions we'll try to address with some resources on the web page. Give us a day or two to get those up, folks, and you can check them out. And here's some additional resources that Mari is sharing with us. So thank you so much. Any last words that you'd like to pass on? Any? Okay. Well,
so thank you so much. I hope this was useful, and you have my contact information, and you feel free to reach out, and I will try to connect you with the appropriate services or resources as needed. It's been an honor for me. Thank you for the opportunity.
Thank you so much. Just great altogether. So everyone, we're just about finished for now. This I believe the program will shut down. So you guys can log off, and we'll be posting this stuff on the website, www.agingny.org/education-events/webinars, and you will find it there. Thank you guys all for participating, and thank you, Mari, for your wonderful work. Everyone have a great day.
Great. Bye-bye.
Bye-bye.